Therapeutic Update lecture series that is organized by the Medicinal Drugs Committee of the Sri Lanka Medical Association. I'm told that we have to wait for a little while until the Zoom is, they have got it ready. So we'll just wait for a few minutes until the technical issues are sorted. Thank you for understanding. Mentioned earlier, this is organized by the Medicinal Drugs Committee of the Sri Lanka Medical Association. We have regular therapeutic updates where the current therapeutic aspects of different topics are dealt by a specialist in that area. So today we are very happy to have Dr. Kishara Gooneratne, who is the consultant neurologist at the General Hospital Hambantota, and he was just now telling me that he also does honorary service at the National Hospital of Sri Lanka, particularly giving multidisciplinary care for patients who have reflex epilepsies and also very resistant epilepsies, where they are assessing them for surgery. So I think we have a young upcoming neurologist, and it's my pleasure. He was my student as well in the faculty. So it's my pleasure to introduce Dr. Kishara Gooneratne and invite him to do the lecture on therapeutic update on adult epilepsy. So,
yeah, good afternoon, and thank you very much for that kind introduction. And at the outset, I'd like to thank the SLMA for inviting me to talk to you all today. So I'll be talking to you. I'll be going through a few definitions initially, and then I thought it would be good to sort of discuss a few case histories, and I would expect a few answers from the audience as well. All right, okay. So let's go on with a few definitions. First is the definition of seizure. A seizure is a set of clinical symptoms that are associated with abnormal electrical activity or excess electrical activity in the cortex of the brain. And the symptoms that the patient generally experiences and what we generally see depends on which part of the brain is activated or is hyper-excitable. For example, you will see motor manifestations of seizures if the motor cortex is activated, or if, for example, you will see sensory symptoms or sensory aura, or the patient will experience a sensory aura as a consequence of activation of the sensory cortex. So the symptomatology or the semiology, as we would generally put it in the language of epilepsy, is a result of abnormal activation of that particular part of the brain. So a good idea of functional neuroanatomy, with a good idea of functional neuroanatomy, you might be able to sort of localize and as well as lateralize these seizures. So that's what a seizure is. So what's the difference between a seizure and epilepsy? Epilepsy is the propensity to have more and more unprovoked seizures. So what do I mean by unprovoked seizure? So we should, to understand what an unprovoked seizure, we should understand what a provoked seizure is. And a provoked seizure is when the seizure threshold, there's a reduction in the seizure threshold which is transient and due to a certain etiology, and once we correct the cause, the seizure threshold comes back to normal and the patient does not have any seizures. So that's a provoked seizure. And we're not talking about provoked seizures, we're talking about unprovoked seizures. So examples of provoked seizures are what's there on the slide. And that's anything, say for example, fever, infections, and the common causes that you would experience in the wards would be electrolyte imbalances such as hyponatremia, hypoglycemia. All these are what we call provoked seizures, including alcohol withdrawal. So that's all these are provoked seizures. And these patients, that it's very important for us to understand that these patients, this particular cohort of patients, do not need any long-term anti-epileptic treatment, and that's why the distinction between a provoked seizure and an unprovoked seizure. And epilepsy is a disease entity where these patients have unprovoked seizures, and these are the patients who need long-term anti-epileptic drugs. I hope that was clear. Okay, so the definition of epilepsy has changed over the years. The operational definition given by the International League Against Epilepsy changed in 2010. That's over a decade ago. So it's not that new, but I suppose this part of the region, I suppose this is maybe new. So prior to 2010, the definition of epilepsy was if you have two unprovoked seizures 24 hours apart, that patient was labeled as a patient who has epilepsy. Now the definition has extended a little bit more, and even after a single seizure, unprovoked seizure, with this definition we are able to diagnose patients with epilepsy. So even if you have one unprovoked seizure and your rate or recurrence risk for the next 10 years is over 60%, those patients, that cohort of patients, are also classed as patients with epilepsy, and these particular patients probably need long-term anti-epileptic drugs. I'll give you an example. So, for example, if a 70-year-old patient comes to you who's got a stroke maybe 6 months ago with a single seizure attributed to that structural deficit that was as a result of that particular stroke, right? That patient has a 10-year risk of a second seizure or a third seizure and a fourth seizure occurring of more than 70%. And that particular patient, even after a single seizure, can be diagnosed as a patient with epilepsy. Okay, so the definition has expanded and now included those kind of patients as well. So if that patient comes to you, you need to start them on long-term anti-epileptic drugs. I hope that's clear. Okay, and also if a patient comes with an epilepsy syndrome, again you can diagnose patients to have epilepsy. Now, what's an epilepsy syndrome? And that's a cohort of patients where they have very similar clinical characteristics, where the clinical features, the seizure type, the age of onset, the family history, EEG findings, investigations, treatment, and prognosis, they have common characteristics. And what would be the common epilepsy syndrome that we would generally see in patients in childhood? Does anyone know? Childhood absence epilepsy, that's a typical example of an epilepsy syndrome, where the patient has a typical characteristic seizure type, which is an absence seizure, okay? Has the typical EEG pattern, right, where you see a 3 Hertz pattern, spike and wave discharges on the EEG. They have a typical age of onset, which is generally between 4 and 6 years of age, right? And they also have a prognosis where these seizures or the epilepsy terminates at the age when they during their teenage years. So if 12, 13 years of age, their seizures are no more. So these characteristics are commonly seen in this particular group of patients, so we class them as a syndrome. And even after a single seizure, if they fit into that clinical syndrome, we can diagnose them to have epilepsy. So in childhood, the stereotypical example, even after a single seizure, would be, I don't know if anyone's heard of benign Rolandic epilepsy. So if you've heard of such a diagnosis, even after single seizure, typical EEG pattern, typical age of onset, we are able to, even after single seizure, diagnose them to have epilepsy because they have an epileptic syndrome. So I'm not going to talk about childhood epilepsy, but in adults, these are the epilepsy syndromes that we would generally encounter. Juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures alone, and 3 other epilepsy syndromes which are not that common, and these 3 are the more common epilepsy syndromes that we as adult neurologists would generally encounter. Right, so just a little bit about epilepsy syndromes and the diagnosis of epilepsy syndromes. Alright, okay, so we've gone through the definition of what a seizure is, we've gone through the definition of what epilepsy is, and now what we would generally try to do when a patient comes to you is that we would try to class these seizures, whether this is a focal onset seizure or whether it's a generalized seizure. So what's the difference between a focal onset seizure and a generalized seizure? Focal onset seizure is where the seizure starts from a certain part of the brain, and that is consistently from that particular part of the brain. For example, if a seizure starts from the left frontal lobe, day in, day out, the seizure that particular person experiences will start from that left frontal lobe. The difference between a generalized seizure and a focal seizure, so for example, these seizures that start from the left frontal lobe might propagate and involve the opposite hemisphere as well, and if that happens, they experience what's called a focal to tonic-clonic or a secondary generalized seizure. Now the difference between generalized seizure and the focal onset seizure is in generalized seizures they do occur from in a certain part of the brain. Say for example left frontal lobe, it can start from the right temporal, but there is no consistent site in which the seizures start from. Okay, so that's the difference. So in generalized seizures it can start from any part of the brain, but there is no consistent site. Whereas in focal onset seizures, there is a consistent site in which the seizures start from. Okay, so there is a difference, and why we need to differentiate the two is because it has an implication on treatment. Okay, so that and why have I included a picture of the brain with the demarcations of functional cortex is that we need to understand that in focal onset seizures, the semiology depends on which part of the brain is stimulated. For example, if you have occipital lobe epilepsy, you will have these patients will have experience a visual aura. If the patient has a seizure occurring from, say, the auditory cortex, they will have an auditory aura. Yeah. So if patients have frontal onset, focal onset seizures, they will have various types of motor manifestations. Okay, so it's a very simple concept, and so you need to basically analyze the seizure semiology and depending on your analysis, come to a diagnosis whether the seizure is either focal onset or generalized. And I've gone through what generalized seizure would be. Okay, so if a generalized seizure can occur from any part of the brain, but it rapidly engages both hemispheres. It doesn't have to spread to involve the whole cortex, but it rapidly engages both hemispheres. It can start from any part of the brain, right, left, frontal lobe, occipital lobe, parietal, wherever, but it rapidly engages both hemispheres. I hope the distinction between focal onset and generalized seizures conceptually is clear, and this is a graphical representation of what the ILA, the newest classification of epilepsy seizures are. So what they generally divided the seizures into focal onset, generalized, and unknown. So if you don't know, we don't know. So it's always better to say that the seizures are of unknown onset. Again, because it has bearing on treatment and management. So an example for focal onset seizure would be the typical and the commonest type of seizures that we know of are seizures that originate from the temporal lobes. Right? So often they will have motor as well as non-motor manifestations. If they have non-motor manifestations, they would generally have auras. Say for example, they might have an aura of an epigastric rising sensation, an aura of say abnormal smell. So those are all non-motor manifestations of focal onset seizures. They would then progress on to lose awareness. So if they lose awareness, then it's a focal onset seizure with with impaired awareness. So there are seizures where they retain awareness as well. So what you really need to know is you need to basically classify these seizures, whether they are focal onset or generalized onset seizures. And this is the seizure classification which you should be aware of. We don't now use complex partial, nomenclature is completely changed. We don't use partial seizures, simple partial, complex partial seizures anymore. So that nomenclature is no longer used. Okay, so you diagnose that this patient has, say, either focal onset seizures or generalized seizures, but you need to find out an etiology as well. So it's not only diagnosing the patient's seizure type, you need to find out whether this is due to either structural cause, genetic cause, infections, metabolic, immune, or often nearly 20 to 30% of patients, there will be no etiology that could be identified, so unknown. So that's what you generally do when you're seeing a patient. Okay. Starting anti-epileptic drugs in this day and age is very, I would say, a little complex, because now we've got a lot of anti-epileptic drugs, as you can see in this graph, that are available to us, and it's pretty daunting and sometimes confusing as to what anti-epileptic drug we should choose for our patients. As you can see, we used to have carbamazepine, valproate, phenytoin freely available in the 90s, 80s and 90s, and from 1993 there's been an explosion of the number of drugs that are available for patients with epilepsy. So we class these agents into first generation, second generation and third generation. So any drug before 1993 is a first generation drug, 1993 to 2008 would be a second generation drug, and after 2008 would be a third generation drug. And then more and more drugs are being introduced into the market. Okay, so and what's different now is there are lots of drugs which act on various types of receptors. I'm not going to go through them today, but as you can see, a lot of drugs acting on the sodium channel, presynaptic sodium channels, some of the drugs acting on the AMP receptors, the novel drugs which act, say for example perampanel, one of the newer drugs in epilepsy acts mainly on the AMP, postsynaptic AMP receptor. So this is just a diagrammatic representation of what drugs do what at the level of the receptor. Okay. So starting an anti-epileptic drug, what do we generally, what's our objective? We need to choose an appropriate anti-epileptic drug which is most likely to be appropriate for that particular seizure type, okay, and should not cause undue side effects. Okay, so it's a balance. So therapeutic effect versus toxic effect of the anti-epileptic drug, and our objective should be zero seizures with zero side effects. And often that is often a challenge, because often anti-epileptic drugs do affect quality of life, and almost all the drugs they suppress the CNS, and there are often cognitive side effects, However, our objective, which may or may not be realistic, would be to have zero seizures and zero side effects. So that's the objective. And how, what are the therapeutic considerations that we should have when we start an AED would be the patient's seizure type, with the medical history, possible comorbidities that the patient could have, and also the patient's individual circumstances, all of which are factors that we would generally consider before we start an antiepileptic drug on patients. And what you need to understand is that some anti-epileptic drugs may be very effective in certain types of certain epileptic seizures and seizure syndromes, but some of the anti-epileptic drugs may be contraindicated as well. For example, most of the genetic generalized epilepsies, example would be juvenile myoclonic epilepsy, the epilepsy syndromes that I mentioned in my previous slide, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. Those epilepsy syndromes, there are certain drugs which can make those the seizures in those particular epilepsy syndromes worse. For example, carbamazepine, phenytoin, which are sodium channel blockers, can worsen these seizures. So those are contraindicated. Pregabalin, gabapentin, again, vigabatrin, all of those are contraindicated in those particular types of epilepsy syndrome. So you need to, that's why it's important for us to make an accurate diagnosis before we start an anti-epileptic drug. So it's not as simple as one would think. And some of the AEDs are very effective in controlling seizures, but maybe is unsuitable for particular groups of patients because of side effects. For example, does anyone know of an example? For example, so if a patient comes with juvenile myoclonic epilepsy, the first line drug would be sodium valproate. Okay, but if the patient is a female in the reproductive age group, valproate may not be your first choice. So because of its effect on the teratogenic effect of valproate. So it's so certain drugs, it may be very effective for that particular syndrome, but in the context of that particular patient may not be the most suitable drug. Okay, so some AEDs may be effective in one or two, but not all multiple types of seizures. For example, some of the epilepsy syndromes might have multiple seizure types. Right? They might have generalized seizures, they might have focal onset seizures. Out of the generalized seizures, they may have, say, for example, myoclonic seizures. An example would be lamotrigine. Right? So lamotrigine in certain genetic generalized epilepsies might worsen myoclonic seizures. So, but lamotrigine is very good in controlling generalized seizures as well as absence seizures. So you need to understand that certain drugs may worsen seizures, and there is no what we call cohort of thyroid. So it's a very individualized treatment that we would generally try to initiate. Preferred sort of anti-epileptic regime would be monotherapy. Unfortunately, we don't see that often in our patients. We see a lot of patients on very subtherapeutic doses and patients who are on 2 or 3 anti-epileptic drugs. So what happens generally is you start them on anti-epileptic drug, they come back with a seizure, then without actually titrating the dose up, we actually we tend to use a second drug. And then they come back with another seizure, then we go on to a third drug, and that would be wrong practice. The practice would be to titrate a single anti-epileptic drug to either to the highest dose or highest tolerated dose. And if the patient is on polytherapy, the recommendation is to convert it to monotherapy, because polytherapy will have a lot of additive side effects. All right. Okay. So this is a very busy slide. Just to emphasize that certain types of seizures. So it's the importance of classifying focal onset seizures versus generalized seizures versus unknown onset seizures is because of the drugs, right? Say, for example, your first line drugs for a focal onset seizure would be a narrow spectrum or anti-epileptic drug, which is generally a sodium channel blocker. So, for example, carbamazepine, oxcarbazepine, lamotrigine are all sodium channel blockers, right? Of course, levetiracetam is a SV2A synaptic inhibitor. So, the first line, so you need to understand that why we classify seizure type is because the effectivity or the efficacious drugs differ from seizure type. So this is just to illustrate, this slide is just to illustrate that. Okay, so you need to not only understand what anti-epileptic drug works for which type of seizure, what type of epilepsy, you also need to know the maintenance doses and up to which dosage that we need to titrate. There are T-half and also there are some common side effects. And this is just to illustrate that you need to know all this before you actually prescribe an anti-epileptic drug. Okay. I'm not going to go into this. Okay. Anti-epileptic drugs do interact with other drugs. So you need to know the enzyme inhibitors versus the enzyme, the inhibitors as well as the inducers, so that you know, okay, so this drug is going to interact with the drugs that the patient may be on, the other drugs that the patient may be on. And often the interactions are associated with the older generation of drugs. So most of the drugs that were available before 1993, which is valproate, phenytoin, carbamazepine, all of the drugs are either inducers or inhibitors, including phenobarbital. So inducers, example would be carbamazepine, phenytoin, phenobarbital. Drugs that inhibit, the stereotypical example would be valproate. And often all of these, what we call the older generation drugs, are protein bound as well. So that again makes them unpredictable with an unpredictable efficacy. Okay, so that's just, and you need to when you are starting patients on anti-epileptic drugs, you need to have a discussion with the patient, explain to them what the most common side effects they would experience would be, the likelihood of success. That's also very important. Not all anti-epileptic, the patients with epilepsy respond to anti-epileptic treatment. So the general rates are around 70%. So only 70% actually become in the sense they respond to treatment. Actually, a large cohort of patients, which is approximately 30% of patients, actually become pharmaco-resistant. So not everybody becomes seizure-free on anti-epileptic drugs, and that's very important to understand. So you need to discuss about recording and reporting seizures, adverse effects, as well as potential precipitants with your patient before you start an AED. These are the common side effects with some of the common drugs. All of them cause somnolence because these are all CNS depressants. Rashes, very common with lamotrigine, phenytoin, phenobarbital. Renal stones, topiramate, zonisamide. Cognitive side effects, phenobarbital, topiramate. Paresthesia, they can have paresthesia in the hands and feet and a metallic taste in their mouth. They can have hypertension, very common, carbamazepine, even more common with oxcarbazepine. Right? Behavioral changes, very common with levetiracetam, often aggressive behavior, and we often experience this, and you need to ask these from your patient. Ask for these side effects, because certain side effects patients don't come out with, because they don't attribute that particular side effect to that particular anti-epileptic drug. For example, aggression. If you don't ask, they might have disputes at home because of the drug. Right? So it's very important for you to ask that. All right. Okay. So those are the common side effects. Okay. So let's start we'll discuss a few cases which makes this a little more interesting. Okay, so the first one, I expect a few answers from the audience. Yes. A 21-year-old woman presents to you after experiencing a first-time convulsive seizure. A friend observed the patient suddenly falling at home and convulsing for 45 seconds. Afterwards, the patient was lethargic for 15 minutes, but then recovered completely without residual neurological deficit. She sustained a tongue bite during the seizure and was incontinent of urine. What is the most appropriate next step in the management of this patient? Okay. Initiate an AED, obtain an EEG and neuroimaging study, perform an LP for CSF analysis, or do nothing. People for number 1, 2, all right, 3, 4. So, yeah, absolutely agree. So you obtain an EEG and neuroimaging. So this is a new onset seizure in an adult. So why do we do all this? Why do we do an MRI and EEG? And that's because we want to predict the chances of recurrence, or to make a diagnosis of epilepsy versus just a single seizure. Because approximately 8 to 10% of the population will have a single seizure. They will experience a single seizure in their life, and that does not mean that they are epileptic patients. Right? It is only about approximately 2 to 3% that have recurring seizures. So you will see that the bulk of patients will not have a seizure subsequently, but you might start them on anti-epileptic drugs. And anti-epileptic drugs are for a long period of time. You can't just stop within a month or two. The AED treatment would not go on for years. Right? So, just to illustrate, so the risk of a second seizure occurring, if the EEG is normal, your MRI is normal, is approximately 20 to 30%. But if the EEG is abnormal, that risk goes up to 60 to 70%. And then, if you remember the operational definition, your seizure recurrence risk is more than 60% over the next 10 years. So that particular patient can be diagnosed as having epilepsy. All right, so by doing EEGs and MRIs, what we do is risk stratify. We try to see the risk of recurrence. And if you have a structural lesion, sorry if you can't see that, neither can I. Right? Okay. So if there is a prior injury to the brain, or there's an insult, if the EEG is abnormal, so for example, if you have the highest predictor for seizure recurrence is a generalized epileptiform discharge on the EEG. So you're guaranteed that the patient is going to have another seizure. So that patient is diagnosed. That patient should be on long-term anti-epileptic drugs. And if there is a neurological deficit, for example, if the patient is a stroke patient, has a seizure, the example that I illustrated to you before, patient is going to have a very high chance of having another seizure. And also if the patient had experienced a nocturnal seizure, a seizure during the night while he or she was asleep, then the seizure recurrence is quite high. So you need to have these, fulfill these two for you to make a sort of, to stratify the risk of recurrence. Okay, so if the recurrence risk is high, obviously you start them on anti-epileptic drug. So if it is a focal onset seizure, we use a narrow spectrum anti-epileptic drug, versus if it's a generalized seizure, we use a broad spectrum anti-epileptic drug. And if you don't know, we would generally use a broad spectrum anti-epileptic drug. So examples for a narrow spectrum would be common sodium channel blockers like carbamazepine, oxcarbazepine, eslicarbazepine, phenytoin. Those are the examples for a narrow spectrum. Broad spectrum one would be levetiracetam and lamotrigine, as well as valproate. So these are the recommended anticonvulsants which you would use for a generalized seizure versus a focal onset seizure, or previously partial seizures. Okay, previously known as partial seizures, right? Okay, so the second case. This is a 14-year-old boy who's thinly built, comes to you with a generalized convulsive seizure. This is his first generalized tonic seizure. On further inquiry, he complains of lightning jerks, especially in the morning, and he often drops things as a result of this. His EEG is below. Wouldn't expect you to read EEGs, but so that's a discharge that you see, okay, which is generalized, okay. What is the drug you would choose for this patient? Carbamazepine, pregabalin, gabapentin, topiramate, and valproate. Anyone for 1, 2, 3, 4, and 5. A lot for valproate. Okay. Any reason why topiramate is not suitable? Anyone? Cognitive side effects, okay. He'll wither away, he's thin. So topiramate is effective in. So this patient's got what's the clinical diagnosis? So it's got a epilepsy syndrome. So that was not his first seizure. The lightning jerks are myoclonic seizures. So he's got myoclonic seizures, he's got a generalized seizure, he's got an EEG very, very suggestive of a diagnosis of juvenile myoclonic epilepsy. So it's an epilepsy syndrome, right? And so let's talk a little bit about. So valproate is what would be my first choice. So we talk about juvenile myoclonic epilepsy. It's a genetic generalized epilepsy, and the typical seizure types are myoclonic seizures. They have generalized tonic seizures, and sometimes, very rarely, they might have absence seizures as well. Age of onset, typical age of onset between 8 and 26 years of age, generally between your teenage years. So if a teen comes with their first generalized tonic seizure, do not forget to ask whether the patient has myoclonic seizures, especially in the mornings when they wake up. They may topple over their tea, their milk. They may drop their brush when they are brushing their teeth. So very important for you to ask that, and we often do not ask, because the clinical diagnosis changes and your drug of choice changes because of an accurate diagnosis. Again, they have a very typical EEG. I'm not going through the EEG, but it's what we generally say epileptiform discharge with a. For the neurology trainees, I don't see any anyway. It's a frontocentral maximum 3 to 6 hertz, generally more than 3 hertz frequency discharge. It's a very characteristic EEG, and approximately 1/3 of them are actually photosensitive. Treatment: valproate, levetiracetam, lamotrigine, clonazepam. What you should be aware of is that though lamotrigine is indicated for this kind of juvenile myoclonic epilepsy, it can worsen myoclonic seizures in a certain proportion of patients. And your accurate diagnosis also involves prognosis. These patients require AEDs, lifelong AEDs. And so you cannot take them off AED. So that is also very important. Okay. Case history. Third one. A 17-year-old female student attends your practice with generalized seizures. The EEG shows a generalized spike and wave discharge suggestive of idiopathic or genetic generalized epilepsy. The seizure frequency is highest around the days of menstruation. What drug would you choose? Number 1, 2, 3, 4, 5. Okay. Half-hearted responses. So she is a female. What does she's got a genetic generalized epilepsy. Drug of choice would be, most efficacious drug would be valproate. Yes. However, she is in the reproductive age group, and these patients will need AEDs for life. Okay. So valproate would be your first choice. However, patient is in the reproductive age group, and I would suggest levetiracetam. Okay, lamotrigine would be my second choice. However, if I started this patient on lamotrigine, I would advise that the patient needs to look out for worsening seizures if the patient had myoclonic seizures. Okay, so levetiracetam good enough because so these are the risks, relative risks of malformation, major congenital malformations. As you can see, the highest risk is in valproate. So much so that now it's a red label drug in Europe. It is no longer recommended in our guidelines as well. If you go through the national guidelines, I think published by the obstetricians, it is again not recommended. We as neurologists do use it, however, in certain circumstances. All right. Okay. So valproate, highest risk, you wouldn't use it. As you can see, if you go down, the lowest risk would be what? Again, levetiracetam, oxcarbazepine, lamotrigine. Those are three drugs which would be deemed as safe in pregnancy. Right. So those are the drugs which we would generally try to promote that patient should be on, even though the patient is having a genetic generalized epilepsy. So these are the risks of major congenital malformations associated with the various types of anti-epileptic drugs. So what's catamenial epilepsy? If you remember, the seizures were associated with her menstruation, exactly. And if they are associated with the cycle, then we class these patients as catamenial, or they have catamenial epilepsy, where approximately 75% of their seizures, more than 75% of their seizures, are associated with their cycle. Right? And there are three common patterns: premenstrual, peri-ovulatory, and or seizures that occur during the luteal cycle. Why is this important? It's important for us to tailor the AEDs, because we can always increase the medication during that period because it's predictable. Or we can use what we call short-acting anti-epileptic drugs such as clobazam to tailor their seizure control. So you need to have that knowledge so you need to analyze the seizure frequency versus their cycle, and then see, okay, are they clustering around a certain period of the month? Okay, and then this is because of the hormones or estradiol to progesterone ratio. Okay, so higher the estrogen to progesterone, estrogen is supposed to be epileptogenic, or promotes more seizures. Progesterone conversely so. Okay. Another case. Now the previous patient is now 18. She's 17, now 18. Has a BMI. She's been overeating. Okay. Now has a BMI of 29 because her A-levels are close by. Stress eating. She has severe migraines as a result of her stress. She's sitting for the A-levels and she's clinically depressed. What treatment option would you choose now? Okay, number 1, 2, 3, 4. Few for 4. Valproate? No, obviously. Alright, so a lot of people have chosen topiramate, mainly because of the BMI and the migraines. So it's a good drug to treat migraines. I often use topiramate quite often, and it's a good drug for prophylaxis, absolutely. However, what are the problems with topiramate? I have a psychiatrist here, so she will tell you that a lot of problems with depression, cognition. Right, so those are the two main problems with topiramate. It's good for migraines, it's good for weight loss. People do use it as a means of losing weight. However, it does have cognitive side effects. She's sitting for the A levels. Right, word finding difficulty is very specific to topiramate, and it can worsen depression. So what would be a more weight neutral drug out of the lot? Probably lamotrigine. Okay. So now, why lamotrigine? And this is why. Sorry, very busy slide. It is weight neutral. It is sometimes effective for myoclonic seizures, but can worsen myoclonic seizures. However, you need to balance everything out, right? Main advantage of lamotrigine in this case is that it causes less cognitive side effects and over sedation compared to other treatment options. And in early studies, patients with epilepsy who were taking lamotrigine reported increase in subjective sense of well-being. And it's actually, lamotrigine is positively psychotropic, right? And now used as a mood stabilizer as well. Yes. And it appears to inhibit serotonin, dopamine, and noradrenaline, and that's how it works. And it has proven efficacy in the maintenance phase of treatment for bipolar affective disorders. I'm not a psychiatrist, however, apparently that it has an added advantage. Does it have an effect on migraine? The answer is we don't really know. Right? However, there have been certain studies that have suggested that migraine with aura, there is an effect on migraine with aura, so that may have a beneficial effect on patients with specifically migraine with aura. Okay. AEDs that worsen depression: barbiturates, levetiracetam, vigabatrin, topiramate. Right. So you need to have this piece of information in your head before you actually prescribe. Levetiracetam, perampanel, topiramate worsens aggression. The aggressive behavior is very common in especially levetiracetam, and that's what I have seen in my clinical practice. Is that a lot of patients have problems because of the aggressive, the side effects that result in aggression. Okay. Moving on. Now your patient is 22 years of age. She's not planning to conceive in the near future. The idiopathic epilepsy diagnosed 5 years earlier is now under control. Now it's on lamotrigine. She's asking for contraceptive advice. What options are available, right, for her? What would you recommend? People for number 1, that's the combined oral contraceptive pill. 2, 3, 4. Okay. Any problems with the oral contraceptive pill? No? Okay. So actually the answers are actually 2, 3 and 4. All of these are options for contraception in this particular patient. What's the problem with the oral contraceptive pill? Yeah. Okay. So just a little. So AEDs and contraception, right? So we need to advise patients who are in the reproductive age group who come with epilepsy and are on an AEDs on contraception. It's very important, and you need to know which interacts with specifically with the oral contraceptive pill. So the enzyme induces a high potential of interaction between AEDs and oral contraceptive pills, since both utilize the same isoenzymes, so all the CYP3A4 pathway. Oral contraceptives are metabolized by the liver. They are highly protein bound and have low variable bioavailability, and inducing effects of some AEDs on estradiol and progesterone may explain. So, carbamazepine, to lesser extent oxcarbazepine, phenytoin, are all enzyme inducers, and they can result in contraceptive failure, and you need to know that before you prescribe. And these are the, as I said, the enzyme inducing AEDs, the non-enzyme inducing AEDs, and the ones which are highlighted are actually the ones which are very commonly prescribed. And if you can see on the slide, the lamotrigine has 3 stars. Can you see that? Yeah. So generally the AEDs basically interact with the oral contraceptive pill. In the case of lamotrigine, the oral contraceptive pill, the estrogen contained in the oral contraceptive pill interacts with the lamotrigine, reducing its bioavailability and increasing metabolism to about 40 to 60%. So, and that's why it's important that these patients who are on lamotrigine are not prescribed the oral contraceptive pill which has estrogen, because 3 months later they will have worsening seizure control, and you will say, oh, you'll be increasing the lamotrigine dose, whereas what you should be doing is stopping the oral contraceptive pill and offering an alternative method of contraception. Okay. Next one. So this lady is now pregnant, right? She's on lamotrigine and on folic acid. What would you do? Now she's pregnant. So you systematically increase the dose of lamotrigine over the pregnancy. That's number 1. Number 2, discontinue AEDs during pregnancy. Continue lamotrigine unchanged throughout the pregnancy. Change to an alternative AED. Okay, anyone for number 1? 2, 3, 4. Change to an alternative. Okay. Right. Actually, I would prefer number 1. So we run a tertiary level epilepsy clinic for pregnant mothers at NHSL. If you actually go through our notes, we actually systematically increase levels of or the dosing for lamotrigine. Why? We'll see. So it is general. So the general recommendation is that you don't change AEDs when the patient is pregnant, right? So even if you think that the seizures are under control, because abrupt discontinuation of medication may precipitate seizures even among women who no longer require the medication, and that's important. So often when a patient who is pregnant comes to us, we generally are very reluctant to stay, even if we think that the patient doesn't really need the anti-epileptic drug, because that might result in a very catastrophic event. Because pure AED withdrawal can result in catastrophic seizures. Okay, so, and you should understand that offspring of women with epilepsy have a risk of congenital anomalies which are 2 to 3 times greater than the general population. May have a high risk of developing epilepsy themselves. And goals of treatment during pregnancy are: 1, decrease the incidence of congenital abnormalities in the infant. So therefore you need to give them AEDs which are less teratogenic, reduce fetal exposure to maternal convulsions, and reduce fetal exposure to anticonvulsant drugs. Right? Okay, so those are the goals of AED therapy during pregnancy. This slide is the reason why we should be increasing the dose for lamotrigine, and that's because not the first one. So the reasons for reduced or variations in AEDs during pregnancy are multifactorial. Could be number 1, could be due to non-compliance, because often mothers think that these drugs are teratogenic themselves and they stop the medication. That's very important for you to actually ask whether the patient is actually taking the medication. That's number 1. they are more prone to constipation and malabsorption. And there is an increase in AED elimination because of increase. There's an increase in EGFR and there's a lot of drugs that are washed out. And there's a change in volume distribution, and there's also a reduction in the albumin. Right, so protein bound drugs, especially the older generation drugs like phenobarbital, carbamazepine, phenytoin, all of which can have less free levels of drugs in the system. That's because of the reduction in albumin. And also, there is, as you can see, with lamotrigine, there's an increased clearance of approximately 185% of lamotrigine. Right? So, there's a drastic drop in the drug levels during pregnancy because of the increase in estradiol, or the estrogen, over during the course of the pregnancy. So, we would expect a drastic drop in lamotrigine during the second trimester. And we generally beef up the medication. Ideally, it should be based on AED levels. Bit of a controversial subject, but I'm not going to go through that now. So, these patients would generally require AED monitoring. We don't have that here, but we do increase the medication over the pregnancy. So lamotrigine, carbamazepine, phenytoin, levetiracetam, all of which needs ED monitoring. AED doses are increased systematically during pregnancy. That's what exactly this patient needs. And what you should do after the pregnancy is rapidly reduce the dose, because they often become toxic post-partum. Right? So you need to review these patients very quickly so that you to prevent these patients having drug toxicity. Okay. I think last case, I think. Okay. 68-year-old male patient has come to you with spells that are described as episodes in which he would go blank and he would have repetitive grasping movements of the hand. He confused for 2 to 3 hours. Following these episodes, he was diagnosed with Alzheimer's and is on rivastigmine for this. And he's on warfarin for atrial fibrillation. What is your choice of medication? Number 1, number 2, 3, 4. So those are the 4 options. No, nothing. Okay. So again, I would choose lamotrigine in this particular case because again, valproate carbamazepine would interact with the patient's drugs and the warfarin that is already on. Why not topiramate? Topiramate has very severe cognitive side effects and is already cognitively challenged. Okay, so potential for drug interactions is extremely important, especially when you are prescribing in the elderly, if the patient is over 65 years of age. Older AEDs such as phenytoin, phenobarbital, carbamazepine and valproate are all enzyme inducers, and valproate is an enzyme inhibitor. We've repeated this particular thing over and over again, and that can have a profound effect because often patients who are over 65 years of age have comorbidities and they are also on other types of drugs, and therefore we would generally use a drug which has less interactions, and the newer AEDs actually provides that advantage. Whereas, say for example, lamotrigine, levetiracetam, they will have very little interaction with other drugs, and therefore would be our first choice. Newer AEDs with again the same thing. Newer AEDs with few or no interactions such as lamotrigine, levetiracetam may be more suitable in this cohort of patients. Cognitive impairment is common in these patients. And in such patients, certain drugs such as topiramate and zonisamide would not be your optimal choice. Again, valproate, not a good drug to use in the elderly. They can cause cognitive problems and also Parkinsonism as well. Osteoporosis is a very common problem in the elderly. So we would generally shy away from all types of enzyme inducers, and also valproate has also been reported to cause reduced bone density as well. Not so much with the newer AEDs, and currently the recommendation would be lamotrigine if the patient is over 65 years of age, because of it has very few interactions with any of the other drugs. It has a positive psychotropic effect, has very little cognitive side effects compared to the other drugs. Okay. Two more slides and then I'm done, I think. Problems with AEDs, especially in the elderly, is because there's reduction in serum albumin levels. Therefore, drug binding is affected, especially in the older AEDs. I've repeated this before. Many of the AEDs are metabolized by the liver again, and the metabolizing efficacy of the liver decreases after 40 years of age. And the elderly have a very narrow therapeutic window, and you need to start. So the old dictum when we are starting an anti-epileptic drugs for anyone would be to start slow and go slow. In the elderly, you go slower, you start lower and slower. So it should be your doses would be not as high as you would prescribe in a patient who is younger, and your titration would be also at a slower rate. Okay, so last slide, conclusions. So your choice of AEDs in treating epilepsy is not as simple, rather it needs very careful consideration before prescribing. Okay, and AEDs can adversely affect quality of life of the patient, which is often under-recognized due to emphasis on seizure control. Yeah, so that's all I think I have. Thank you very much.
Okay, thank you, Kishara, for that very comprehensive coverage of the topic. I think you went from basics to addressing very complex therapeutic issues and practically through case studies. I think it will be very useful for all particularly the registrars in training. So I'm sure you would be happy to answer some questions if you have any. Yeah.
Hi, I'm a psychiatrist. I'm a psychiatrist, and one scenario we come across a lot is that people who have epilepsy on anti-epileptics come to our clinics for follow-up, which was a practice in the olden days, especially in the periphery. Now, a lot of these patients are on phenobarbital and phenytoin sodium. Is it advisable to actually refer them back to neurologists to have a review of the medication? Because most of the time they're stable. Would you say that a neurologist would need to kind of take a look at these drugs to see whether they are suitable?
Of course, yes, because one is whether they need place is a query, because if they've got stable epilepsy and the epilepsy is under control, they may actually not need the drugs. That's one. Secondly, they may have unrecognized side effects. What we generally experience is because they are on phenobarbital, they become very, they are dependent on phenobarbital, and we find it very, very difficult to actually wean them off phenobarbital, and that's a practical experience. You often the patient comes to you, they may not have seizures, but they yearn for the phenobarbital. Right? But yes, because they may be on inappropriate anti-epileptic drugs in the first place, right? Because the diagnosis may have not been epilepsy in the first place. I've seen so many patients who are on anti-epileptic drugs for syncope, vasovagal syncope, because vasovagal syncope is one of the commonly misdiagnosed what you call seizure mimics, and patients are inappropriately started on anti-epileptic drugs. So I think in the long term, I think it would be advisable to refer these patients to neurologists to, one, review the diagnosis, whether it's actually indeed epilepsy, and two, would be whether they actually need the AEDs are not.
Any other questions?
I have a question now. You mentioned about monotherapy. So if you think of now, you are increasing the dose and the patient is not responding, then you have to wean off the first drug and then start the second. You can't. Is that the way?
Yes. So two options. You can wean off the drug and then start on the second drug. However, when you're weaning off the first drug, there is a chance of worsening seizure control. You need to state that to the patient, and then this day and age, and also the expectation of the patient is a quick fix, and the clinician is actually under a lot of pressure to actually control their seizures very quickly, and that's reality. So one option is actually to add on. However, the side effects can make things worse, and then once we come to a dose that makes sense, I'm talking about the second anti-epileptic drug, then wean off the first. There's also the other option of using a very short-acting bridging therapy such as clobazam, so that would cover the period in which you taper medication. But you're right, ideally we should be tapering off the first medication and then starting off on the second.
Yes, questions. Do you need to add the folic acid for lamotrigine and levetiracetam?
So the idea of having folic acid is due to, so what do you mean? So, the folic acid can be used for preconception to prevent neural defects. There is no hard evidence for that. But it has studies have shown that once the children are born, they have their cognition is much better on patients who are on folic acid. If they are in the reproductive age group, I suppose they may be on folic acid. But why we put patients on folic acid because of the folate deficiency that you can have because of enzyme inducers. So if the patient is on carbamazepine, phenytoin, yes, but not so much lamotrigine and any of the other drugs. Okay. So actually, I rarely prescribe folic acid in any of the. It's a knee-jerk reaction. It doesn't matter. It doesn't really make excess goes through the kidneys. That's fine, but I think it's quite unnecessary unless the patient is on an enzyme inducer or the patient is in the reproductive age group and has a potential of getting pregnant.
Okay, can I just ask you now? You mentioned about measuring therapeutic drug monitoring, particularly in pregnancy. So, do you use, like, for example, lamotrigine levels and so on? Is it available in the private sector? Anywhere? Yeah.
I came to you also.
That's right. Yes. Yeah.
The kits are very expensive, but we have the facility to do it.
Yeah.
Unfortunately, it's the kits that are expensive. We don't do it actually.
Do it, yeah.
To be honest, the centers that I worked in the UK, again, it differs from center to center. So in a very top class, high functioning center, yes, the AED levels are available. But even in the UK, if you go to say a DGH, you won't, that facility is not available. So even in other countries where you expect those facilities to be available, it's not. So I think you need to use a little bit of your clinical sense and titrate the dose, even knowing that, especially with lamotrigine, that you're going to lose most of the drug as we go closer towards the end of pregnancy.
Okay. Yeah, so because I think we can try to actually establish some of these therapeutic drug monitoring facilities.
Yes.
So
And it will be very, very advantageous because
Yeah.
we'll know exactly where we are with regards to and whether we really need to titrate it up, because now it's a blind procedure.
That's
Right,
right.
blind thing to do.
Yeah, I think, so you highlighted some very important topics, aspects regarding, I think, valproate. Now, UK in somewhere in 2018, they put out a pregnancy protection plan, isn't it? So do we have anything like that in Sri Lanka, particularly with respect to valproate, at least?
So valproate is, people are still getting pregnant on valproate. But I think the College of Obstetricians have actually issued a guideline where valproate is a sort of a red label drug. But I don't think it has translated into practice where we see a lot of patients who are on valproate getting pregnant. However, if you analyze the data across all 4 large pregnancy registries, which actually involve most of the Caucasian population, which is in the UK, North America, Australia, and in Europe, right? The main, valproate, the dosage, which causes teratogenicity or increased teratogenicity, is about 650 milligrams. And often our population, we actually we achieve seizure control at far lesser doses. So one might always think that valproate might not be causing that many major congenital malformations because our population may be having a dosage that is less teratogenic. But now the data is out where patients who are the children who are born to patients who are on valproate, they actually fare worse with regards to IQ. They have higher incidence of ADHD within the first 5 years of life. So we might be seeing that, but maybe unrecognized.
Yeah, so I think that's one of the main reasons, because I think those learning difficulties they have identified in 1 in 10 children.
Absolutely.
So I think that's one of the main reasons. And we did a study, I think about 5 years ago, about anti-epileptic drug use in pregnancy, and we found that 25% of the patients were on anti-epileptics and by the first trimester, and which was changed by the 3rd trimester, which is really, no point in doing that, because
so often, organogenesis is completion is between 11 and 16 weeks.
Yeah.
So anything after that does not really make sense.
Makes sense. So that's what we always teach. Also, don't try to change once you have diagnosed a pregnancy, because already the harm has already been done.
It may be catastrophic if you do change it also, because that may be the drug that is the most efficacious, and then you will have worsening seizure control, and that might have an effect on the pregnancy itself. So there's a high increase of intrauterine death, higher incidence of antepartum hemorrhage, postpartum hemorrhage, preterm delivery, and so on and so forth. So, so changing the drug at a later stage does not really make sense.
Okay, yeah. And one more thing about, actually again related to the question that you asked about the tailing off the drug before stopping it. If you have found that one is not efficacious. I think one reason why the patients may be on polytherapy is you intend to stop it, but at the time of initiating one drug, but very often the patient is seen by someone else, or at a junior doctor at the next clinic visit, and then it continues because no one reviews the medication, and the fact that you decide to stop it probably is not recorded in the book. So therefore I think that has to be documented and written clearly, so that you try to tail off and stop it in another 3 or 4 months time. So those are the things, I think, practically important aspects that people should be paying attention to. I think we are now, it's time. So in the absence of any questions, I thank Dr. Kishara for that excellent lecture. I may have given anti-epileptics lecture to you in the faculty, but today I learned a lot from you. So roles have reversed. So thank you so much, Kishara, for that lecture. And it's my pleasant task to present to you this token of appreciation. Thank you.